Just hiding everyone. All right. Okay, so yeah, as we mentioned, I'm going to be going through the cranial nerves. I'm going to be making a few assumptions. These are that you are roughly familiar with what a cranial nerve exam is, because I think if you guys are third and fourth years, you've been doing them for a couple of years. So the actual procedural elements of it, going through the exam physically, I'm going to assume you know roughly what I'm talking about when I bring certain elements up, and that you are familiar with it, or you're going to be practicing soon regularly. And so from that, I think the aim of the session, therefore, is to look over the structure of the exam, to remind ourselves and flesh out some concepts, specifically regarding pathology and the unusual signs that you might see and the things that you might want to mention to your examiner during the exam. Does that sound fair enough? And please say if you'd prefer it if I included, you know, other things. That's just how I've pitched this for now. Okay. So the plan, therefore, is to just briefly look at the anatomy so we know what they're looking at. And then examination-wise, we're going to go through the exam in a stepwise way, talk about the functions of the nerves, some relevant histories as we come on to the relevant nerves for that history, and talk about what pathologies and their relevant signs that will come up. And a big focus on the pathologies for this session. Okay. And then we've got some cases at the end as well. So what are we looking at? We're looking at the cranial nerves, cranial from cranium, so the skull. And then you know what a nerve is. It's a bundle of neurons, essentially. So it's the nerves in and around the skull that originate from the brain or the brainstem. And that's what separates them from other types of nerves. And we're doing this to localize a lesion to a cranial nerve or multiple cranial nerves. And the differentials in neurology are always the localization of the lesion in conjunction with the history, the time course. So the history can do the rest. We're trying to figure out where the pathology is. Okay. So these are the cranial nerves. I'm sure we're all familiar with this. I don't really remember stressing about learning this before OSCEs. I think it would be a bit unfair to ask you to label a diagram like this, but just so we're familiar with it. There it is. There's a few distinct anatomical features that are worth remembering. The nuclei are all on the dorsal side of the brain stem and brain. They all emerge eventually, except for the trochlear nerve. So the trochlear nerve emerges dorsally and then sort of comes around like this. There's the rule of fours, which will help you split up where the nerves are emerging from. So nerves 1 to 4 emerge above the pons, and that's 2 in the forebrain, 2 in the midbrain. So 1 and 2 forebrain, 3 and 4 in the midbrain. 5 to 8 emerge from the pons itself here. And then 9 to 12 emerge from the medulla. That's a good way of just sort of separating out the emergence of the nerves there. And each nerve exits the skull at a specific point as well. I've thrown this in there. We're not going to go through this because I'm sure you're fairly familiar with it, but it's a nice picture that summarizes the functions of the nerves. So look through this in your own time, please do. And another thing that I remember learning before my exam, and then probably thinking that it was slightly redundant, was learning the skull exit of the nerves, and they're fairly specific, but it's there for your reference if you're interested. Okay, so I put this bit in because there are some easy marks available for just remembering this short list. It's not exhaustive, but causes of any cranial nerve palsy. If you're looking for that answer, the examiner's saying what can cause this cranial nerve palsy or that: diabetes, MS, multiple sclerosis, stroke or a vascular lesion, tumor, sarcoid, lupus. And as I said, that's non-exhaustive, but that's a really good bet. And if you're struggling for an answer, this is a good place to start. Okay, so we're going to move on to the exam now. When thinking about cranial nerves, the important thing is that, one, you can go through it clearly and you know it, you've really practiced it, and you're not going to get that here. You're going to have to do that practicing with someone. Just do it on repeat until you just don't have to think about it. But the other element of it is that often the brief will say you only need to test nerves 1 to 6 or something. Maybe say only do the nerves that are relevant to the eye, or maybe they'll ask you to do 7 to 12. The point is you need to be able to start halfway through or finish halfway through. So just be a bit flexible with it and read the brief carefully. So as always, any exam, introduce yourself. You need to get the name and the date of birth of the patient. Maybe you need to ask for a wristband if they're in a hospital environment. You need to explain what you're going to be doing. And I normally say, I'm going to be testing the nerves of your head and neck. You need to then gain consent for this, make sure that they understand why you're there and that they're okay with it. And then you need to explain positioning. And for the cranial nerve exam, you want to be sitting 1 meter away, opposite from the patient, and your eye lines need to be as equal as possible. And that might mean just sort of raising or lowering a chair, or if they're way off, you're going to need to sort of get yourself into perhaps an uncomfortable position to make it work. So the equipment you'll need, most of this will be in the cubicle for you in the OSCE if you require it, and much of it you won't need because it's sort of it's too formal, it's too extensive. So pen torch, I think I have one, but I couldn't find it for today, which is unfortunate. But you all know what one is. A Snellen chart, which may be in there, but I'd imagine it would be unlikely. Ishihara plates, I couldn't see them being in there. Ophthalmoscope and otoscope might be useful. Cotton wool, some cotton wool to test sensation, a neurotip as well, and a tuning fork are much more likely to be present in there. So they're your sort of 3 key pieces of equipment. A glass of water, again, could be useful, as we'll see later as we get onto the exam. So begin with the general inspection, as always, any exam. I see, as far as I can tell, this is missed in cranial nerve, probably more than other exams. So comment on the general appearance. Is the patient alert? Have they got their eyes closed? Are they looking at you? Are they looking around the room? Do they appear distressed? Do they look in pain? And then, as always, check the area. Can you see walking aids? Can you see glasses on the table? Can you see medications, for example? The point is just state the obvious, and don't leave something out if it's really obvious for then to wait for the correct section, if that makes sense. Just say it. Okay, so the olfactory nerve. This for me is as simple as just asking the question, have you noticed any changes in your sense of smell or taste recently? So strictly it's only sense of smell, but I tend to get 2 birds with 1 stone here and just ask about taste as well. If you want to do it more formally, you could use sort of smelling identification pots, they need to distinguish the smells. And the most formal version is the University of Pennsylvania smell identification test. But really the question is adequate in of itself, I'd imagine. If you are going to test each nostril individually. So pathologies that can cause a patient to have an olfactory nerve dysfunction, pretty common, I'd imagine, right now. COVID, if they've had any sort of trauma to the olfactory nerve, that will cause dysfunction in the nerve, obviously. Stroke, and so that's a stroke to the parietal cortex, and specifically the region that's responsible for processing that sort of information. Parkinson's disease, you can have destruction of the olfactory bulb, and then congenital causes. Some people are just born and they can't smell. And another condition that might cause a similar unilateral anosmia would be a deviated septum, where actually the septum's cutting off the nasal cavity. Okay, moving on. The optic nerve. So I see this as the start of the eye section now. Inspect the eyes. You're looking for any signs of infection or inflammation. You're looking around the eyes for swelling and any signs of trauma or scars. You're looking at the eyelid itself. Is the eyelid drooping over the eye? Is this a ptosis? And then coming onto the eye, the sclera, making sure it's white, the iris and the pupil, making sure the pupils are symmetrical, they're of equal size, roughly. and shape as well, that the shape's round and spherical. And the mnemonic that allows you to get through the optic nerve pretty efficiently is afferent, and this is what I've used, which is acuity, fields, reflexes, and optic disc. Okay, so first, A, visual acuity. Start off by just saying, have you had any changes to your vision lately? Do you wear glasses or contacts? Establish their baseline. You need them to be at their baseline to assess the function of the nerve itself, regardless of any refractive errors. You might just ask them to read something like a magazine. If there's anything in print in the cubicle, ask them to read it. Ask them to read it one eye at a time, and whilst using their corrective equipment, so either glasses or contacts, make sure they're using that. Formally, you'd like to assess with a Snellen chart, and if it is the case that there's a Snellen chart in there, definitely use it. Just make sure you're using it appropriately. So if it's a full size chart, you need to ask them to stand 6 meters away, and obviously if it's not full size, you need to reduce that distance proportionally. But I'd imagine it'd be adequate just to say you would like to use one. So here's a Snellen chart for your reference, and for to really make the examiner feel comfortable that you know what you're talking about. These are Ishihara plates that are used to assess colour vision. So someone with impaired colour vision might struggle to distinguish the number from the background. So yeah, probably not necessary, but makes the examiner feel very comfortable with you, and that they don't have to focus too much, which is the aim. Okay, so what can cause a reduced visual acuity? Refractive errors, and if the patient is not wearing their glasses or contacts, the refractive errors are going to produce reduced visual acuity. And so just there for your reference. It could be amblyopia, particularly in kids. It could be a lens defect, whether that's a corneal ulceration, anything that's obstructing the eye, sort of exteriorly. Optic neuritis will cause decreased visual acuity, and any lesion to the visual pathway anywhere. And although we associate that more with visual field defects, as we'll come on to, of course, that's going to reduce the visual acuity as well. Okay, so visual fields. This is mainly split for me into three parts. So we've done A of afro, and this is now F fields, and it's split into three parts again. So inattention, where essentially we are saying to the patient, are you able to hold attention to each half of your visual field? So you're going to ask them to have both eyes open, tell them to focus at your nose roughly, and you're going to hold out two fingers, one in each side of their visual field, and you're going to sort of waggle like this and sort of alternate, left, right. And as you're doing this, you're saying, can you point, whilst fixing your eyes and your head on me, can you point to which finger I'm waggling? And then at some point do them both together as well. And they should be pointing to the correct side, whichever's waggling. It's showing that they can hold attention in their visual fields to wherever you're doing the finger waggling, basically. Then a good screening test as you continue on from there is, can you see my whole face? Maybe you can do that before attention. The next section is essentially to map out their visual field eye by eye and compare that to yours. So you're going to ask them to cover one eye. You come down to their eye level or up to their eye level, whichever. Ask them to cover one eye, and you're going to cover the opposite eye. So their right, your left. And then you take ideally a red hat pin or something with just sort of a vibrant, at a white or red end to it. And you're just going to go from the center, draw outwards upright until it goes outside of their vision. You ask them to tell you when that happens, and you're just trying to line that up to yours. And you're just roughly trying to figure out, 1, 2, 3, 4. So that's sort of 4 directions for each eye, and you're trying to map their visual field onto yours. And you repeat that with the other eye, and you're trying to get a gauge for if their visual field is adequate. So this is what it might look like. This is just the schematic of the visual fields. The next section is to assess the blind spot. So the blind spot is essentially like a scotoma but it's meant to be there. And it's where the optic nerve enters the retina and becomes the retina. And the optic disc has just a much lower density of cells. They're actually going to pick up visual information. So we're all walking around with blind spots, and our brain does a lot of the work to remove that as a problem for us. But if you take a red pin and you get eye level with the patient, bring the pin up to eye line, covering one eye, of course, and move to the right. So you're actually going temporally, should be about 15 degrees. You say to the patient, tell me when this disappears. And it will go into the blind spot, and then you keep moving it to the right or temporally, and you say, tell me when it appears again. And the idea is you're trying to map the borders of the blind spot to yours. Okay, that's good. Okay, so what are the pathologies here? Visual inattention, otherwise known as hemispatial neglect, is generally caused by contralateral parietal stroke. So not really a cranial nerve pathology, but it is tested anyway. And these are the sorts of, so these are these sort of copying, drawing tasks that patients with contralateral parietal strokes will do, just to give you an idea of what they're sort of going through. Patients are asked to copy these images, and this is what they produce. This is typical, where they're not actually able to even perceive the sort of left-hand side of these images. So this is a right parietal stroke, and when asked to draw from, just for their imagination, they might get the outline of the face. They come to do the right eye, and then they cannot perceive that they do not have a left eye present, and you can imagine the same here. So it's not very nice. Okay, I'm sure you've all seen this before. This is important to know. It's worth just sort of going through it in your own head, making sure you understand it. I've highlighted one that seems to come up all the time, which is bitemporal hemianopia. I've sort of broken it up like that so we can see what's going on. So it's bitemporal, which means the field loss is on the temporal side, both sides. It's hemianopia because half the visual field is lost. And so that is an optic chiasm lesion. So it might be a pituitary mass or craniopharyngioma, anything in the chiasm. It's affecting the central chiasm. Something that comes up in written exams, I'd say a bit more, and I've seen questions on it. It is, if you're having this a quadrantopia, and it's contralateral, of course, how can you distinguish a parietal lesion from a temporal lesion of these sort of two streams from the occipital lobe? This Pitt's mnemonic is parietal inferior, temporal superior. Allows you to say that if the quadrantopia is inferior, so it's an inferior quadrantopia, it's a contralateral parietal lesion, and if it's a superior quadrantopia, it's likely a contralateral temporal lesion. So just to make sure understand where this is coming from. Maybe they'll ask you to talk about it in your OSCE in the question. Maybe not. Okay, the blind spot. Really, what you're looking for here is an enlarged blind spot, which is where you're having optic disc swelling. It's either going to be bilateral or unilateral. Bilateral, most of the time, is going to be papilledema. So that's swollen optic discs in the context of raised intracranial pressure. So perhaps that's a space-occupying lesion. If it's unilateral, it's going to be a single swollen optic disc. So that might just be optic neuritis or a non-otoritic ischemic optic neuropathy as well. Cool. Okay. So you've done AF. So you've done out of afro, you've done acuity, fields, and now we're on to reflexes, right? So visual reflexes. You might want to darken the room, although that's not possible in OSCE always. Mnemonic now is perla. Pupils equally reactive to light and accommodating, or something to that effect. You need your pen torch here, and you look first looking for the direct and consensual response, and then you're going to do the swinging light test, right? And so this is going to involve separating the two eyes of the patient and just shining the light in the left eye first, for example, observing the direct response. So that's the pupil that you're shining into, and you're trying to see whether that pupil constricts. And then you're going to remove the light, let the pupils relax, and then put the light back into that eye, and this time observe the consensual response in the other eye. right? And then take the light away, let the pupils relax. And you repeat that process on the other eye. So observing both the direct and consensual responses. Once you've seen both and you're happy with both, you're then going to do the swinging light test, which is basically blocking off each eye from the other, moving light and shining it into one of the pupils, holding it for a few seconds, quickly shifting it over to the other and holding it for a few seconds and quickly shifting it over. Repeat that process a few times. And what you want to see there is that there might be a very transient period of dilatation, but the pupils quickly react to light each time you present it and constrict. The last part is accommodation, where you're going to ask the patient to fixate on something behind you. So it'll be the edge of the booth, the wall, and you're going to present something into their vision. Helpfully would be a neurotip or something like that. You say 3, 2, 1. If you could just fixate on the tip, and you'll see the eyes converge, working with each other. So you're not getting one eye going skew if or whatever. They're converging equally, and the pupils will constrict, and that's adequate accommodation. And you know that you've just tested eye movements there partly. So that's a good cue for you to go on to the third nerve then. Okay, so anisecuria approach. Anisecuria is the state of pupils being unequal in size. So that's this situation here. What do you do about this? You want to figure out which eye is affected. So how would you do this? The question you need to ask is, do dark or light conditions exaggerate this difference? And the trick is light, large. So if you place, for example, this pair of eyes into a lighter condition than they are already in, the larger pupil, if the anisecuria becomes more apparent in this setting, the larger pupil is affected, as you would expect both pupils to constrict even more than they currently were in the lighter setting. So this pupil, the unaffected pupil, would constrict even further and exaggerate this difference. So that's a really good way to remember which is the affected. You then need to figure out whether this is an afferent or efferent pupillary defect, right? And what I mean by that is it the optic nerve that's picking up the light, or is it the oculomotor nerve that's constricting the pupil that's the problem? It's really simple. If it's an afferent defect, you're not going to get either a direct response or consensual response on shining light into the affected eye. If it's an efferent defect, whilst you will get a consensual response while shining light into the affected eye, you're not going to get either a direct or a consensual response on the affected eye. The pupil will remain stuck essentially on that eye. So just have a think through that yourself and just see if you could, it's quite logical if you just think through it yourself. It's well worth doing just so you understand it. The sign that always comes up, and I hear a lot of talk about it, is it's the relative afferent pupillary defect of the swinging lights test, right? And this is essentially saying that it's not a complete deficit of the afferent pathway. You have a partial deficit that isn't noticeable when you test the eyes individually for their direct and consensual responses. There is still some reaction, but only when you test the eyes side by side, i.e. you do a swinging light test, do you observe the relative defect that's there. And so the affected eye is the eye that when you bring the light to it, there is a considerable and prolonged dilatation of the pupil. So it actually dilates in response to light. Okay, so what pathologies can cause these? So complete afferent and efferent defects are just cranial nerve, palsies. So this is trauma, tumors, uncal herniation, so increased intracranial pressure, for example, causing a third nerve palsy, or anything that will cause an optic nerve palsy as well, similar things. RAPD, relative afferent pupillary defect, is classically associated with optic neuritis and multiple sclerosis. And in multiple sclerosis, it is an optic neuritis that presents. 20% of cases, of MS cases, present with this as their first presentation. And the other pathology we should bring up is meiosis, so that's failure of the pupils to dilate, right? So I think the typical situation that we need to know about for exams for this is a Horner's syndrome. So this is looking like a partial ptosis, so drooping of the eyelid, a miosis, so failure of the pupil to dilate. It's a constricted pupil, and anhidrosis. So on that side of the face, the sweating function is essentially lost. And this is because you're having damage to the sympathetic pathway somewhere. And there are 3 areas that this is going to occur. We don't have to focus on this too much. Essentially, just know that there's 3 orders of neurons where this can occur. And any of them can cause a Horner's syndrome. The common one that we need to know about, I think that comes up a lot because it's quite interesting, is the Pancoast syndrome, where we have an apical lung tumor compressing the sympathetic pathway of the 2nd order neuron, and the pathway is compressed enough to cause a Horner's syndrome in the eye. Trauma anywhere can cause this. So, note a lateral medullary syndrome or brainstem stroke. If you have neck surgery or thoracic surgery, that can cause that. Carotid artery dissection is the other one that I think is worth knowing. So if you have sort of an acute onset Horner's syndrome associated with pain, that could well be a carotid artery dissection. It's compressing the 3rd order neuron up here. Cavernous sinus syndrome can cause it equally. Just interesting, if it's a 3rd order neuron, generally, because of the branching of this nerve here, the anhidrosis is absent in the 3rd order. Cool. Last thing you mentioned, I'd like to examine the back of the eye. I don't think they'll ask you to do this. It's worth mentioning for completeness. Okay, onto the eye movements now. So the oculomotor nerve, trochlear nerve, and the abducens. First thing to ask, have you experienced any double vision ever and recently? And also, have you experienced any pain in your eyes? What's moving? And then you're going to do the H test for diplopia and for observing the movements and nystagmus as well. So this is essentially getting a pen or preferably something bright, a neurotip or something, and you're saying, I need you to keep your head completely still. You get your head level with theirs. They can have 2 eyes open, and you ask them to, with both eyes, obviously, track the neurotip, and you're going to move it in an H type shape. And the important thing when you're doing this is you're watching the eyes, making sure they're moving with each other appropriately. They're not sort of, one isn't going off in a certain direction. And the other thing is you need to make sure that they are aware of any double vision that they experience during the exam. And if they do experience double vision, which direction is it? Is this experienced in it? Is it the horizontal superposition of images or vertical? You might see hints of nystagmus as you get to the extremes of your eye movements, and you can elicit these by speeding up your movements towards the end. That will elicit a nystagmus if it's there, and that's important to note. Okay, corneal light reflex. So this is different from the corneal reflex, the corneal light reflex, which I've got a picture of later on. This is essentially just shining a light and looking for the reflection of the light in their eyes and making sure that the reflection is sort of equally positioned in their eyes. I'll show you a good picture after. I don't remember ever doing that in my OSCE. And I don't think I learned it either, but it's good to know. It's identifying misalignment of the eyes, basically. And then the cover test, which is a similar concept. You're identifying misalignment. You ask them to fix at a point on the wall, for example, and then you cover up one eye of theirs. So you're covering up the patient's eye, and you might see the affected eye at the point you cover the other eye. It sort of corrects and it moves slightly. And it's because it's the brain realizing that that's the primary source of visual information now, and it needs to correct. Cool. Okay, so the extraocular muscles, know roughly what they do, and we all know this. This is a really useful mnemonic. Lateral rectus 6, so the abducens nerve, superior oblique 4, trochlear nerve, and the rest are 3. Really helpful. I'm sure we're familiar with that. Okay, so what causes problems with moving eyes? Thyroid disease, Graves can cause ophthalmoplegias. Is it neuromuscular? Are you seeing evidence of fatigability of the eyes? Is it getting worse as you go through the exercise? Is it myasthenia? Is it getting worse throughout the day? A good history element there. Is it Wernicke's? Is it associated with confusion or ataxia? Is this a cavernous sinus syndrome? And here I have this picture, and you can appreciate the cavernous sinus. And if there was pathology in here, be it a thrombosis or a vascular lesion, you get compression of multiple nerves, including the extraocular muscle supplying nerves. And of course, as always, it can be specific palsies. So 3, 4, and 6. Trauma is most common, followed by diabetes causing like a mononeuropathy, and tumors, aneurysms are all involved as well. Okay, so this is the third nerve palsy. And before we move on to that, I just want to show you the corneal light reflex. So this is what I mean. The reflection of the light, you can clearly see, is not placed within the pupil at the same point. So obviously this is an exaggerated version. You can clearly see that the eyes are misaligned anyway, but that's the concept, that this little reflection here is not equal. But back to this, the cranial nerve 3 palsy. So you can notice a couple of things. One, the eyelids having to be held up, because if it wasn't being held up, the patient would have ptosis, be drooping. The eye is depressed. It's looking slightly down compared to this, and it's out. So it's down and out is the phrase used. And also the pupil is dilated. So these, all these things put together, it leads one to think about a complete third nerve palsy, right? Some good history elements to look at. This could be trauma. This could be, increased intracranial pressure causing herniation. It could be direct compression of the nerve from a mass. Posterior communicating artery aneurysm seems to come up a lot in relationship to this palsy. So have a look at that. And then there's this concept of the pupil sparing palsy, where let's say you have all these features, but the pupil remains to be the same size as on the other eye. The idea is that that's actually more likely to be diabetic in nature, because this is where, if you imagine you've got all the blood supply to the nerve here, the bit that's prone to ischemia is central here, and the central bit of the nerve is the fibers that supply the eyelid and the extraocular muscles, and actually the outside is the bit that supplies the pupil constrictor, and that's preserved. It's more likely to be diabetic if the pupil is spared. Okay. So that's the eye section done. So the trigeminal nerve split into 3 sections roughly. The sensory, which is just the testing the sensation in the 3 divisions, the 3 branches of the trigeminal nerve: ophthalmic, maxillary, mandibular. The way to do this is just ask the patient to close their eyes, give them some sort of reference, say this is what the neurotip feels like, this is what the cotton wool feels like. If you don't have them available, just your finger, this is what it feels like, perhaps on their sternum. And then you say, okay, close your eyes. Tell me when you can feel me touching your face. And I'm then going to move to the other side. Tell me if it feels the same on the other side. So ideally you test this with the neurotip and the cotton wool as well. And you're going to be testing the forehead just right at the midline, over the zygoma, and just right at the midline on the chin as well, making sure it's the same on each side. The motor component of this is involving the muscles of mastication. So you're asking them to contract and release their jaw just repeatedly for a moment. And you're going to be feeling the temporalis, which is just right here, feeling the masseter, and then just asking them to open the jaw while you're offering some resistance, like this. Okay. And then the reflexes involved with this nerve are the corneal reflexes, corneal reflex, and the Georgia reflex. I wouldn't do these in your OSCE, just mention them for completeness, so your examiner knows they exist. You know they exist. Okay. Here's a diagram of the trigeminal nerve, and you can just appreciate where the branches offer sensation, and just make sure you're covering these areas when you're testing the sensation. Okay, facial nerve. You need to start by just inspecting the face. So this nerve innervates the muscles of facial expression and the anterior 2/3 of the tongue as well for sensation. So you're going to be inspecting for tone. Is the face drooping on either side? Is it asymmetrical in any way? And note the forehead sparing if it's present, and that's important, as you might know. The motor control, ask them to do a few maneuvers, and we'll go through them now. But each time they do one, let them do it on their own first, and then offer some resistance. Try and break their posture, and see if they can maintain posture equally on each side with your resistance. So you can ask them to raise their eyebrows, and you're sort of pushing against them. Close their eyes tight, and you're trying to open their eyes. Big smile, and show the lips as well. And you're going to try and sort of push the sides of their mouth down, pursing the lips. So they're trying to close their mouth, and you're trying to open it. Essentially, blow out the cheeks. You can put pressure on each side, and show gums or whichever. Point is that you're testing for unequal resistance on each side. Okay. You might want to ask them about if they've had any particular sensitivity to loud noises, as a branch of the facial nerve has some connection with the 8th nerve, which I'm not exactly sure about, but please check that out. You might want to ask them if they are having sensitivity to loud noises, and you also want to ask them if they've noticed any change in their taste, but we've already asked that at the start, so that's good. Okay. Now, the big thing with facial nerve palsy that seems to come up in exams is it an upper motor neuron lesion or a lower motor neuron lesion? The thing to remember is that the lower motor neuron lesion presents with a more severe looking deficit. The forehead is not spared, right? And in the upper motor neuron lesion, the forehead is spared. And the best way to think about this is to say the phrase, if you're asked why, for whatever reason, that the forehead, the upper face, is represented bicortically. So there is representation on both cortices for the forehead, but not the rest of the face. So if it's an upper lesion, everything gets knocked out on the contralateral side, but the other cortex makes up for it. Cool. Causes of facial nerve palsy. If it's a lower motor neuron lesion, Bell's palsy is the idiopathic nerve palsy. Risk factors include pregnancy and diabetes, but we don't really know what causes it. Sarcoidosis can cause a lower facial nerve palsy, and Ramsay-Hunt syndrome is a good differential to be aware of, and that's going to come in a sort of syndrome along with auricular pain maybe, and vesicular rashes in and around the ear. Upper motor neuron includes strokes, tumors, etc. Okay, treatments. This is just a little added bonus if you want to be up on this sort of thing. Bell's palsy, oral prednisolone and eye care is really important, and Ramsay-Hunt syndrome, which is essentially progression of the herpes varicella zoster virus from the ganglion of the facial nerve. It's sort of it's come out of its latent stage in that nerve. You need steroids and acyclovir pretty soon. Okay, onto the vestibular cochlear nerve. So begin, as always, just asking a general question. Have you experienced any changes to your hearing, any vertigo or tinnitus lately? And then you're going to do a crude hearing assessment, which might just involve just gently rubbing on the tragus of each ear and just making sure they can hear that. Or you might just want to sort of ruffle your fingers together near each ear. It's quite hard to do in an OSCE environment though, where the room can be a bit loud. You're then going to move on to Arooneys test. There's Rooney, and Verbus test, and that's Verba. So they'll help you assess with a tuning fork what sort and where the pathology is. Okay, Arooneys test. Take a 512 hertz tuning fork. You're going to vibrate the fork, so like sort of ping the fork, and then place it onto the mastoid process behind an ear. You're then going to say to the patient, tell me when you can no longer hear it. check they can hear it in the first place, and then say, tell me when you can no longer hear it. At the point where they can no longer hear it, they've let you know, then move it in front of their ear. And if they can then hear it again, the assumption is that the air portion of that exam, they can hear better than the bone portion. That's the terminology generally used, right? And then you repeat on the other ear. And then you do Verbus test, which is you take the same tuning fork, you vibrate the fork, place it on the midline, and you need to ask the question, is it going to either ear louder? Is it louder in either ear? And that's referred to as lateralization, right? And the way I remember this is, I think it's quite useful, is that the W is symmetrical and therefore is on the midline, but the R is not symmetrical when mirrored. So that needs to be done on each ear. So Verbus and Arooneys test. Okay, so just onto some interpretation. The idea is that hearing should be louder in air than bone and lateralized on either side. If bone is louder than air, you need a Verbus test to determine what the pathology is. If bone is louder than air, and then you get ipsilateral lateralization, so you lateralize to the side where bone is louder than air, that's conductive hearing loss. If Verbus test lateralizes away from the side where bone is louder than air, that is complete sensory neural hearing loss. And actually what's happening in Arooneys test is you're pinging the fork, you're putting it on the mastoid, and it's vibrating all the way around the skull and entering the nerve here. Similarly, if air is louder than bone on both sides, but Verbus test lateralizes, generally it is sensory neural hearing loss of the contralateral ear. So Verbus test lateralizes here, it's sensory neural here, given that Arooneys is normal on both sides. Okay, causes of pathology. Essentially, it's conductive or sensory neural, as we've spoken about. Earwax, obstruction, foreign body, otosclerosis, rupture from trauma, all of these can cause conductive hearing loss. And sensory neural, very commonly, presbyacusis, noise-induced hearing loss, toxicity, tumors. And by tumors, really, I'm talking about acoustic neuromas, which are cerebellopontine angle tumors. Meningioma could cause the same thing, but it's less likely here on this angle. Meniere's disease can cause sensory neural hearing loss. And then there's this concept of sudden onset sensory neural hearing loss. And this might be a young person who, for no apparent reason, very quickly loses sensory neural hearing. That's an urgent ENT referral case where they will probably go on to receive an MRI and high-dose steroids. Okay, this is a nice memory aid for ototoxic drugs. So canal Q. Cool. Okay, glossopharyngeal, so the 9th and the 10th nerve, the vagus nerve. Inspect, ask them to open their mouth, get a good look at the soft palate and the uvula. And of course, you look at the tongue as well. That is the next nerve. Ask them to say ah, and you're shining the pen torch in at this time. And you're making sure that the uvula is moving okay. It's not deviating to one side or the other. And you might ask them to cough as well. This is the point where the glass of water would come in handy. You might ask them to swallow and make sure that they're not struggling to swallow. There isn't any vocal changes after they swallow, which might indicate a dysfunction. But often it might be a bit too much for OSCEs. Similarly, the gag reflex is looking at cranial nerves 9 and 10, but it's not appropriate in OSCE. It can be quite uncomfortable for the patient. Okay, but make sure you mention it and make sure you know the examiner knows you know it. Okay, hypoglossal nerve is the final nerve. So this is, you've inspected the tongue. You want to ask them to protrude the tongue, make sure that it's not leaning or deviating to either side. You might be looking for the tone, any wasting of the tongue. And this is where you do the protrusion of the tongue, and then asking them to press on each cheek, like such. And you're just pushing on the tongue making sure that the power is equal on each side. Okay. So looking for soft palate deformities and uvular deviation. The uvula deviates away from the side of the lesion. The tongue deviates towards the lesion. So the tongue never lies is the way to remember this. Apparently the uvula does lie. And the absence of the gag reflex is indicating a 9 and 10 palsy as well. So here we go. There's a good example where the patient's been asked to protrude their tongue. The right tongue is doing its job appropriately. The left tongue is not able to protrude properly. And because the tongue is deviating to the left, this is a left hypoglossal lesion. A few more things to note. If the tongue's flaccid, wasted, if it's fasciculating, this is a lower motor neuron lesion. The principles are the same as in skeletal muscle, limb muscles. And this is a lesion of the 12th nerve. This situation, the lower motor neuron lesion of the 12th nerve, is also known as bulbar palsy. If the tongue is spastic, on the other hand, and it's contracted, this is likely an upper motor neuron lesion, and this is also known as pseudo-bulbar palsy. So you can appreciate the relationship of these two palsies. MND, of course, can cause both, and causes of the individual palsies include Guillain-Barré, myasthenia, etc. And of course, trauma, tumors, the same principles still apply. Accessory nerve, this nerve innervates the trapezius muscle and the sternocleidomastoid. So test both, ask them to raise shoulders against your resistance. So this is just having your hands on their shoulders and asking them to raise against. You're feeling for unequal resistance, and then ask them to turn their head. Ask them to turn their head one way and place your hand in the middle, and you're resisting them turning back. And again, you're feeling for unequal resistance. Okay, at the end, of course, thank the patient, wash your hands. Then you might want to mention additional things that you didn't get to do. Fundoscopy, otoscopy are common. And then relate it somehow, maybe back to the history that you've been given. You know, do we want an MRI? Do we want formal testing? But a really good bet would be to say that you want to do further neurological assessment. You want to do an upper and lower limb examination. You want to do a cerebellum exam. Right. So I associate cranial nerves a lot more with examinations than I do histories in terms of OSCEs. But I remember in one of my OSCEs, there was essentially something like a cranial nerve pathology history, but it kind of caught me out because it wasn't actually to do with the pathology itself. What you really had to pick up on were the cues that the patient was giving you, and was saying that their condition was getting them quite down, and not only that, were they a carer, but there was a few other things that had gone wrong in their life, and actually it sort of changed into a mental health, almost screening history. So just be aware of that, you know, making sure you're reading the question. Don't just go, it's more of a general tip for OSCEs, but don't just go straight in tunnel vision. Really need to have your lateral thinking abilities on during your OSCE. And yeah, if it is just a cranial nerve history and you think you've figured out that that's the case, just think about the differentials we've talked about today. I think that's a decent overview. There are many more, but hopefully this is acting as a good place for you to structure your work and your reading now. Okay, so we've got some cases now to finish. I didn't even get a chance to look at the chat. I don't know if anyone's put anything, but no, cool. So got some questions. I'll just sort of leave you with these, I guess. Oh, we've got a poll there. Yeah, Catherine set up a poll, thank you. So feel free to fire away.
The poll is completely anonymous, by the way, so no shame in answering whatever you want.
Yeah, exactly. And I'll just run through it quick. So a 33-year-old male presents with visual disturbance. Examination reveals a bitemporal hemianopia, and it's predominantly in the upper quadrants that are affected. Where is the most likely lesion? Right. Cool. Okay, so the poll's closed. And can you guys all see the answers? Yes, you can. Oh no, I click share results. There we go. There we go. You can see. So pituitary is the right answer in this case. So the majority of you guys have gone for that. So well done on that. So we'll just quickly go through. Craniopharyngioma, I think, is the best next guess because it would cause, in exam terms, a bitemporal hemianopia, right? But the key thing with this history is that it predominantly affects the upper quadrants. And if you imagine, that's because the lesion is underneath the chiasm and it's affecting the fibers that run to the retina, which take information from the upper portion of the visual field. The craniopharyngioma is generally from compressing the chiasm from above, and therefore it will be inferior quadrant generally affected. Okay, cool. We're going to move on that one. But yeah, really good guesses all around. Yeah, pituitary on that one. Okay, so this is a 50-year-old female with a 4-month history of worsening tinnitus and left-sided hearing loss. General exam's okay. There's some facial weakness on the left. You do Arooneys test and air is louder than bone on both ears. So that's good. But then you do Verbus test and it lateralizes to the right side, which is the most likely diagnosis. Okay, got some good guesses there. So most of you guys went for acoustic neuroma, which is the right answer there. Meniere's disease is a decent go as well because it would cause tinnitus and hearing loss typically as well. And it would be sensory neural, so it would line up with the cranial nerve exam that's been performed in this history. The only thing is you wouldn't necessarily get Meniere's disease in a sort of 4-month progressive pattern. It might normally come in attacks and they last for a couple of hours and then sort of go away. And it might progress in a stepwise nature. Yeah, and I guess it could be meningioma as well. Sorry, we'll take it back. So it is acoustic neuroma. So this is otherwise known as a vestibular schwannoma. So this is a tumor of the 8th nerve in the cerebellopontine angle, and it's compressing the local structures as well. So they've got mild left facial weakness because it's compressing the left facial nerve. So meningioma could cause a similar presentation, but it's just less likely and much more likely to arise more superiorly. Presbyocusis, she's a bit young, I'd say, and wouldn't account for the rest of the history. Okay, so 32-year-old female presents with visual problems, otherwise healthy. Acuity is mildly impaired on the left. She has some red color blindness. She's struggling to distinguish the color red. There is pupillary dilation on the left eye on the swinging light test only. So only when you're doing the swinging light test do you notice unusual dilatation. What are we thinking about that? Okay, great, cool. Well done to a lot of you. You got that. Multiple sclerosis, easily done. So the idea is that the swinging light test pupil dilation on the swinging light test, think RAPD, think that is a partial afferent pupillary reflex lesion. So it's on the afferent fibers. So you're thinking optic neuritis, you're thinking multiple sclerosis, very common. I think diabetes could cause the same thing, but it's less likely. Occipital stroke would tend to cause not a problem with a single eye, but a visual field more. And cataracts doesn't really fit the history. Okay, last one here, I think. So we've got a 45-year-old male with facial weakness, otherwise healthy. The facial weakness is left-sided, it's unilateral, and there is decreased wrinkling on the forehead. So when asked to sort of wrinkle up their forehead, they can't do it as well. Ear canal is clear, there's no facial pain. What is the most likely diagnosis here? So this is thinking back to relating the facial nerve palsy and trying to figure out, is this an associated lower or upper motor neuron lesion? Okay, yeah, cool. We've got that. So well done, guys. That's Bell's palsy. That is a lower motor neuron lesion. Ramsey Hunt would produce a similar picture, but I sort of tried to rule that out by saying the ear canal is clear and there's no facial pain, so I hope you picked that up. Very good. Okay, cool. So that's basically the talk done, but it's well worth using. I don't know what resources you guys are using, but what I used for OSCEs included this book pretty much the whole time. It's so good in terms of just like having succinct ways of doing things. It's nice to have a book that's quite a small book and you can take with you wherever you need as well. OSCE Stop's really good. Geeky Medics is really good. And then for the neurology section specifically, this is really comprehensive, but also sort of like nice to read and flows and explain things really well. So if you're interested in the neurology side of things, particularly, this book is really good. Cool. Thank you very much and good luck for your OSCEs as well.